All right, hi guys, a very good evening to all of you. Welcome to today's YouTube session, which will actually be a high yield MCQ session, and it will be totally a clinical pattern mixed bag MCQ session where we'll mainly targeting the upcoming NEET PG and FMG examination, and all the questions that we are going to discuss henceforth on the YouTube will be mainly clinical based pattern, very newly framed question directly from the syllabus that you have been given by the NMC guideline. Now let me start this session very quickly, but a quick confirmation from all of you guys. If audio and video both are fine, please give me a quick confirmation. All the students, those who are live right now, you can talk to me, you can reply to all my answers, all the queries that are going to be asked in the live chat option. For anyone who is new, you know the live chat option here, you guys can utilize the live chat option, and pharma will be interesting more than ever that you have seen previously. It's going to be more and more interesting because as we have seen that your pharmacology has now become clinical pharmacology, definitely they will be having more clinical pattern question. Okay, fine. So I have got a quick confirmation from one of you. Let's get started very quickly. But before that, a couple of announcements that if you are subscribing to Unacademy, please don't forget to use the Pharma 10, or you can even use Dr. Siraj Live. You can use either of this code. Both of them are live and active code to avail a 10% off in your subscription. And the new introduction that I would like to introduce here is NEET PG notes. Anyone who is buying a 1-year subscription, you'll be getting a free notes of all the 19 subject, and in addition to everything, as I have already told you, that Pharma 10 will be your savior of another 10%, and or you can even use this to buy subscription like a plus subscription, or you can even buy iconic subscription where you can avail all the benefit of Unacademy and Prep Ladder together. Okay, these are some rituals that are running on the platform of Unacademy, and educator curated test series of biochemistry that was conducted. Then today it was 26 May, so 9 AM we have actually conducted all India mock test. The FMGE 2022 grand test of February will be conducted tomorrow again at the same time. And these are some new batches. NEET PG 2022 PYQ batches. This will be a 2-month batch in which pharma will be covered by me here in around, I think, 4 sessions, so 8 hours. Focus FMG 2022 batch. This is also going to be a 2-month. It will be a kind of a crash course batch where again pharma I'll be covering here in around 10 hours. I'll be covering the entire pharmacology. And another batch that is being launched on the platform is Focus FMG 2022. This is for mainly students, those who are targeting the December examination, December 2022 target exam. All those students, those who are targeting this exam, you can utilize this, and again pharmacology will be covered by me in this batch as well. And next 2023 subject wise, it's a 1-year course that is going to start on March 2, and in this particular batch also I'll be taking care of the pharma, and these are the other faculties along with me who will be taking care of their other subjects. Okay, all right, so I hope all of you guys are ready and we can start. Mohsin Sharif, then it's this batch is ideal for you. Next this one, FMG 2022 comprehensive, so that is going to start on March 2 and it will be done by November 2 2022. It is having everything, live class, test series, MCQ batches, everything will be covered in this particular batch. So you have a lot of time, and if you really wanted to understand how to actually plan your studies, yesterday or day before yesterday I have taken one session on the Unacademy platform that is all a free session in which I have actually discussed how you can actually plan your December studies from now onwards. Okay, so without making any further delay, let's get started, and I'll give you your first case. Read each of these cases. This is all going to be a case based session, So read each of these cases very carefully. A 54-year-old man complained to his physician of palpitation, facial flushing, and vertigo. The man had been suffering from GERD for 3 years. 2 weeks earlier, he was diagnosed with exertional angina. Okay, so stable angina or exertional angina, and was started on the first line therapy for the angina. Which of the following drug most likely caused the patient symptom? So what are the symptom? Like palpitation. So let's say he was diagnosed with exertional angina and he has been given a drug. After giving the drug, he is having facial flushing, palpitation, vertigo like symptom. So which drug among the anti-anginal drug can cause this kind of effect, like propranolol, verapamil, diltiazem, or nitroglycerin? Go ahead, please start giving your answers. All the students, those who are live. Each of these questions are going to be, a clinical base. So all of you guys will enjoy, I'm very much sure, solving each of these questions. They are very basic question, not very difficult one, very basic question. Okay, so as I can see, many of you are actually replying to this very well. So yes, that's the case of exertional angina or stable angina, or in simple term, even if I say, let us say there is angina. Okay, term has been mentioned, stable angina. D, some of you are telling 2, that is verapamil. Okay, others are saying C, that is diltiazem. Okay, now propranolol, guys, it's a beta blocker. Do remember, beta blocker will not cause palpitation. In fact, it is given against palpitation. Verapamil, on the other hand, again, it's a calcium channel blocker, that is a non-DHP calcium channel blocker, acting mainly on the heart, and it will also reduce the heart rate. Verapamil, diltiazem, they both have the similar mechanism of action. They are non-dihydropyridine. They both are going to decrease the heart rate. Now, if you are going to just follow a single symptom like a palpitation, facial flushing, that means it is mainly occurring due to vasodilation. And any vasodilation, we all know, like nitroglycerin or glyceryl trinitrate, GTN is the other name, they will actually be causing vasodilation that will actually lead to fall in the blood pressure. Any fall in the blood pressure, they always have a problem of the reflex tachycardia. In order to abolish, or in order to stop this reflex action that is causing palpitation, we actually add beta blocker as well. Now, as a single drug, if the examiner is going to ask you which drug can cause palpitation, facial flushing, and vertigo, that is none other than your nitroglycerin. Okay, so this is the one drug that is actually associated, and that is why it is actually also contraindicated in migraine patients. In migraine patient, do you see that because of vasodilation, what will happen? Again, the headache will be worsened out, right? क्लियर है? तो सिंपल सा केस बेस्ड सिनारियो आपके एग्जाम के सामने, आपके सामने स्क्रीन पे रहेगा, and you will be given 4 options and you will have to identify, like a very simple one. Let me give you the next case. I'll be giving you short and sweet explanation so that we can do more number of questions. This is actually a PYQ, clinical based scenario, but PYQ. In an outbreak of MRSA in the hospital setting, an ICU nurse has MRSA colonization of anterior nares. Best treatment option is, go ahead, give me the answer of this question, guys. Oral vancomycin, IV cefazolin, topical bacitracin, inhaled colistin. This is actually a true story that there was a hospital in which every patient who is entering into the ICU, they end up getting MRSA. Later on, upon a study, they found out that it is actually, the hospital nurses, the hospital attending staffs who are actually having this MRSA colonization of the nares. So every time they touch the nose, they touch the patient, and then they will be transmitting this infection from themselves to nitroglycerin is sublingual. Yes, Dr. Mohsin, that is the preferred route. The preferred route of glycerin nitrates are sublingual. Go ahead, please. So all of you are actually marking C, others are marking A or 1. Okay, oral vancomycin. Now 2 things are there. One thing is simple question here. that the drug of choice in any MRSA group of infection, guys, is IV vancomycin. We all know this, right? IV vancomycin. But am I telling you that there is MRSA systemic infection, or there is a colonization of anterior nares? This is a confusing question. Many students made a silly mistake. They all marked vancomycin. And second thing, when you say oral vancomycin, please do remember, oral vancomycin is a preferred agent. In which scenario? It is a preferred agent mainly in a patient with the pseudomembranous colitis. Pseudomembranous colitis and PMC is pseudomembranous colitis. So it is out of scenario now. Okay. So for the anterior colonization of MRSA colonization of anterior nares, we will be using a 2% topical bacitracin, or 2% mupirocin we can use. Mupirocin topical we can use, or we can even use topical bacitracin. You can even use this bacitracin. This will be used for this colonization of the anterior nair, and topically both of them are actually a topical agent, remember, for the colonization. Plus you can even use chlorhexidine as well, and for washing you can even use chlorhexidine also by the topical route. Okay, so for the topical route or anterior nares colonization के लिए MRSA के group के लिए we will be using this. Examiner also asks that since we are talking a lot about MRSA, methicillin resistant Staph aureus, can you guys tell me what are the drugs that you can use for MRSA? Quickly, what are the drugs that you can use for MRSA? एक तो drug मैंने बता दिया, vancomycin we can use. What are the other drugs that you can use? Quickly revise. For the MRSA, what else can you use? Anyone who would like to add on to this? I will be using IV vancomycin, that I totally agree. Apart from that, in MRSA group, what else can you use? Very good. As rightly mentioned, 5th generation cephalosporin. Now other cephalosporins are not affected. Do remember that, है ना? Ceftaroline, ceftibiprole, है ना? Other cephalosporins are not affected. Remember that, है ना? MRSA. Methicillin resistant Staph aureus. MRSA का मतलब हुआ methicillin, that is the strongest extended spectrum penicillin that we have. Methicillin resistant Staph aureus. Okay. So when you are looking at the penicillin, there are certain penicillin that are considered as a very stronger one that can actually that are actually resistant to beta lactamase. Those were actually very resistant to beta lactamase degradation. Okay. So one of them will be methicillin. Then we are having cloxacillin, oxacillin, and napcillin, dicloxacillin. These are the stronger penicillins, right? Now, if the bacteria can even invade or can cause breakdown of that methicillin as well, then we call such bacteria as a methicillin resistant Staph aureus. So ceftaroline, ceftibiprole are the 5th generation. Very good. MRSA group के लिए you can use carbapenems as well. That is very well. Carbapenem you can use, and also remember, whatever drug that you can use for VRSA, that is vancomycin resistant Staph aureus, you can also use it for the MRSA, because VRSA is a more severe one, है ना? So all the agents, like let us say, streptogramines you can use, streptogramines, daptomycin. Of course, you can use daptomycin, but the drug of choice remains vancomycin. Daptomycin you can use, oritavancin, dalbavancin you can use, linezolid also you can use, linezolid. Multiple drugs are there, but important ones I have given before you, right? So I hope this much information is good enough for you, and why A is not the answer, that I have also explained all of you. Next case, a 44-year-old man who underwent surgery to remove a lung cancer exhibited pronounced shivering. So operation के बाद he is having shivering. This is a very common. Post-operative shivering is a very common condition, and upon recovering from surgery, an appropriate therapy was started that included फ्लूइड वार्मिंग. ओके, सो फ्लूइड वार्मिंग किस में देते हैं आप सबको ये बात, अगर कभी भी आपने किसी कोई ओटी अटेंड किया है, सो राइट. एंड एन आईवी इंजेक्शन ऑफ ए ड्रग, fluid warming and an IV injection of a drug. Which of the following drug was most likely administered? So when they say IV administration of a drug, they are saying, okay, which drug among the following was actually administered? Is it amitriptyline? Is it indomethacin? Is it fluoxetine? Is it meperidine? Go ahead, please. Mark this. Post-operative shivering. All the students, those were live. Continue to mark. A little difficult one, but remember, amitriptyline being a tricyclic antidepressant, indomethacin being one of the NSAIDs, okay? Fluoxetine one of the SSRI, right? And meperidine is one of the opioids. Among the given choices that we're having, the correct answer remains meperidine. What is the exact mechanism of action? Studies have shown that it's not well known, but they are telling that meperidine, drugs like meperidine, drugs like clonidine are effective drug for the post-operative shivering. So as I was telling, for the post-operative shivering, you are having alpha 2 agonist like clonidine, right? Physostigmine, cholinergic agent like physostigmine, ondansetron, and opioids like meperidine, morphine, fentanyl, tramadol. These are the opioids that are also effective. Now, what is the exact mechanism? The studies have shown not well known, but yes, opioids like meperidine are actually available and they are given for the treatment of the post-operative shivering. ठीक है. So I hope it is making sense. We'll take the next one. A newborn boy whose mother had epilepsy presented with microcephaly, a broad nasal bridge, short nose, cleft palate, hypoplasia of the nose, hypoplasia of the distal phalanges. And I used to give you this information that this drug is reducing the size of everything. जो भी इसके सामने आएगा उस सबका साइज कम होगा, right? So if you have attended the session of anti-epileptic drugs, you know what I'm talking about. And let us see. Drug used by mother during the pregnancy are phenytoin are used for seizure, methyl dopa used for pregnancy induced hypertension, erythromycin for upper respiratory tract infection. During delivery, the woman was treated with diazepam also. The multiple drug has been given, है ना? She has been given phenytoin. If I summarize everything, she has been given alpha methyl dopa. She has also been given erythromycin, and then at the time of delivery, she has also been given diazepam, and also she has been given lidocaine. Epidural anesthesia form में lidocaine has also been given. Now examiner is asking which of these drugs taken by the mother most likely cause the baby's presenting syndrome. Out of the given one, which one will have methyl dopa diazepam, phenytoin lidocaine, erythromycin diazepam, phenytoin only? Very good, Harshil Mehta, but the correct answer first. I think most of you are in favor that yes, it will be phenytoin. And the syndrome that they are actually targeting here is known as your fetal hydantoin syndrome. Do remember, I used to tell you that fetal hydantoin syndrome, everything becomes short. Like for example, there will be microcephaly. If you remember in my regular classes, I have told you, if you have ever attended my anti-epileptic drug class, I used to tell you that everything becomes small. Microcephaly, short phalanges, they cause cleft lip and palate. Okay, then they also cause thin upper lip, short nose, short chin. देख रहे हैं कई सारे features हैं fetal hydantoin syndrome that is usually seen with due to the phenytoin only. So it's a teratogenic drug, remember guys, And phenytoin, also remember, it's a drug that follows zero order kinetics. It's one such drug that follows zero order kinetic, where therapeutic plasma concentration has been asked in the past, 10 to 20 microgram per ml, and that is why it is always and always recommended to do therapeutic drug monitoring. TDM is therapeutic drug monitoring, is always recommended with your phenytoin. Now remember erythromycin. Let me just quickly summarize all of you guys. Can any one of you give me any information about the teratogenic effect caused by erythromycin? Any student have ever read? अगर आपको याद होगा तो लास्ट टाइम में व्हेन आई टुक द यूट्यूब सेशन दैट वाज फॉर सेफर ड्रग इन प्रेगनेंसी, आई हैव टेकन ऑन यूट्यूब safer drugs in the pregnancy or teratogenic drug in the pregnancy. Yes, very good, Dr. Staffi Vishwakarma. That is congenital hypertrophic obstructive pyloric stenosis, है ना, where olive shaped lump is seen at the epigastric region of the newly born baby. I'm talking about the teratogenic effect. Cholestatic jaundice will be seen in the pregnant female, and motilin receptor agonistic will also be seen in the any patient, be it pregnant, non-pregnant. ठीक है, I'm talking about the congenital effect. ठीक है, diazepam could be a teratogenic drug, but not suggesting the feature of fetal hydrogen syndrome. Alpha methyl dopa is alpha 2 agonist. It is relatively a safe drug, highly safe drug is alpha methyl dopa. Do remember that. Okay, let me give you the next. I hope this much information is good enough for this fetal hydrogen syndrome. Okay, this is a little tricky question, and I hope you guys are aware about the fact. Yes, in the previous one, the safer anti-epileptic drug that we have is levetiracetam, brivaracetam, and also lamotrigine. I repeat, safer anti-epileptic drug in pregnancy is SV2A inhibitor, levetiracetam, brivaracetam, and also your lamotrigine. Next case, 51-year-old diabetic woman presented to the emergency room with severe ocular pain. Okay, severe ocular pain, redness, decrease in the vision, colored halos, nausea and vomiting. Ophthalmoscopy revealed anterior chamber inflammation, and tonometry measured an intraocular pressure of 48 mmHg in the right eye. So 48 mmHg सोचिए तो ज़्यादा है ना, up to 19-20 तक माना जाता है, 21 तक माना जाता है कि ठीक है. A diagnosis of an acute glaucoma was made, and 2 drugs were instilled in the conjunctival sac. Another drug was given in the same route 15 minutes after the 2 drugs. Which of the following 3 drugs were most likely administered? So what examiner is actually asking, that looking at the present scenario where the patient is having redness, colored halos, nausea and vomiting, which 3 drugs were given? So right now they have given a combination of your 3 drugs. A combination of 3 drugs has been given here. So which 3 drug has been given to this patient? Is it timolol? Is it apraclonidine? Is it pilocarpine? Is it homatropine, carbachol, timolol? Is it scopolamine, dorzolamide, phenylephrine? Is it homatropine, carbachol, dorzolamide? It's very easy one if you know how to treat this condition. It's pretty easy question. Go ahead, please. All the students, please try marking. Those who are still not marking it and waiting for others to simply mark. Now, out of the given choices, what is the diagnosis that they have made here, guys? Diagnosis here is actually your glaucoma. Yes. This is actually a case of glaucoma. Angle closure glaucoma हो सकता है, because redness, decreased vision, acute onset हमेशा angle closure ही होता है, because open angle glaucoma usually is developing over a long period of time. Acute onset will be mostly angle closure glaucoma. Now always remember, for the treatment you will be using the drug that are having miotic in nature. See, meiotic drug will always increase the outflow of the aqueous humor compared to mydriatic. Mydriatic are always going to precipitate. So mydriatics are contraindicated. One thing. Other are drugs that are decreasing the aqueous production. You can use certain drugs, or you can increase the drug that can increase the aqueous outflow. या तो production को कम कर दो or you increase the outflow. Mydriatics, remember, are contraindicated. Meiotics are used in glaucoma always. Now if you, let's start with option D here and rule out each of these options here. If you are going to start your patient homatropine, simply remember atropine, homatropine, and a cyclopentolate tropicamide, they are actually mydriatic drug. And mydriatic, as I said, is contraindicated. Can I use carbachol? Earlier it was used, but because of the nicotine agonistic property, it is not used anymore. Dorzolamide can be used, yes, but if when you have to choose that which three drugs are used, if two are not used, of course it is ruled out. Scopolamine again is a drug. Atropine again is a drug that should be contraindicated. Phenylephrine again causes mydriasis, again it should be contraindicated. Homatropine mydriatic agent, immediately ruled out. जैसे timolol, can it be used? Yes, timolol is going to decrease the aqueous production. It's a beta blocker, but others are not used. Now timolol is a beta blocker, can it be used? Yes. Apraglutinin alpha 2 agonist, it is having dual action. It will decrease the production and it will also increase the uveoscleral outflow. Pilocarpine is a meiotic agent. It will be causing meiosis and they are going to improve the outflow of the aqueous. So which three drugs are used for the management of the glaucoma? There you go, right? So this type of question also you can expect in your upcoming examination. Do remember that, okay? So meiotics are used, mydriatics are contraindicated, rule of thumb. Do remember that. Okay. Let's talk about the next. A 57-year-old woman had been receiving high dose of betamethasone for 6 months to treat severe relapsing polychondritis. Okay. Because of the ongoing therapy, the patient was most likely at increased risk of which of the following disorders? Right? Which of the following disorders? Exertional angina, osteoporosis, rheumatoid arthritis, ulcerative colitis. Yes, Dr. Aarti. Very good evening. Namaste. Go ahead, all the other students. The patient is on a high dose of betamethasone from 6 months. तो इनमें से कौन सा साइड इफेक्ट एक्सपेक्टेड है? Increased risk of which of the following? I think it's pretty simple. All of you are easily getting it. That steroids. Remember, steroids. अगर eye की बात करें, so ocular side effect, they can cause glaucoma upon topical use, and they can even cause cataract upon systemic use. And I used to give you the mnemonic here, GTCS, that glaucoma will be seen due to topical use and cataract can be seen due to the systemic use. GTCS, very simple one. Steroids that we are having, they are also going to cause very drastic effect on the GI, like peptic ulcer disease. They can cause peptic ulcer disease, nausea, vomiting, peptic ulcer disease. They can also cause weight gain, increasing the risk of diabetes. डिस्लिपिडीमिया भी करा सकते हैं, लिपिड मेटाबॉलिज्म का अल्टरेशन कर सकते हैं. दे कैन आल्सो कॉज योर osteoporosis. Now if I ask you, if I compare the same, that steroid induced, listen to my question, steroid induced osteoporosis is an example of which type of ADR? Which type of ADR? Type, which type of ADR? A, B, C, D, E, F, G, बताइए. Steroid induced osteoporosis is which kind of ADR? This is another extra question that I am putting here. So quiz में भी quiz होगा आपका. If a person is going to take long-term steroid, there are likely chances he will develop osteoporosis. So steroid induced osteoporosis is always example of type डी का तो कॉन्सेप्ट मैंने आपको बताया था ना, डिलेड. तो टेराटोजेनिक अफेक्ट आर मोस्टली डिलेड, है ना. टाइप सी ड्यू टू क्रोनिक यूज ऑफ अ थेरापी, है ना. टाइप सी इज द करेक्ट आंसर. ड्यू टू क्रोनिक यूज ऑफ अ ड्रग, इफ ADR is developing, then we call this one as a type C kind of ADR. Okay, type C. Is it making sense to all of you? Yes, type C kind of ADR, not type D. Okay, it's not type D. Others, please take note, it's not. And in the given scenario, of course, osteoporosis. C steroids are not going to cause rheumatoid arthritis. In fact, they are used for rheumatoid arthritis. They are preferred in ulcerative colitis. In exertional angina, no, it will not be causing exertional angina. Okay, so simple yet very conceptual case-based scenario could be asked in your examination. Another one, 61-year-old male suffering from non-Hodgkin lymphoma was hospitalized for first cycle of the chemo. A pharmacotherapy was prescribed to prevent the chemo-induced nausea and vomiting. So chemo-induced nausea and vomiting के लिए he has been given a group of drugs. The drug regimen most likely included ondansetron. Can it include? Yes, it is a 5-HT3 antagonist. It is definitely used. Aprepitant, substance P, or NK1 antagonist, can it be used? Of course. And which of the following? So we all know there are three drugs that are predominantly used in chemo-induced nausea and vomiting. Go ahead guys, tell me which of the following would that be? Is it Dexa? Is it scopolamine? Is it diphenhydramine? Is it omeprazole? Go ahead please. All of you please try. All the students, those who are live, that in this patient having cancer-induced nausea and vomiting, he has been given to, and which will be the additional drug? Will you be using scopolamine? Other name of scopolamine is hyoscine. Most of you are actually marking B, and there are also some, Samir is also marking B, and some student like Harshil is marking A. Jayansh is also A. Okay, now let us see why so many of you are marking scopolamine. What is scopolamine, guys? What is scopolamine? Hyoscine. It is actually drug of choice in a patient with the, anyone? Scopolamine, hyoscine, motion sickness, right? Motion sickness. Scopolamine, hyoscine, motion sickness के लिए mainly use करते हैं. The correct answer that we are having is steroids, dexamethasone. Highly effective drug, guys, for the management of the nausea and vomiting, है ना? In fact, if you have to choose, let us say 5-HT3 antagonist, it is considered the drug of choice in chemo-induced nausea and vomiting. ये बात तो सबको पता है. But if the examiner is going to ask you that which of the following is the most effective, which of the following is most effective in treatment of chemo-induced nausea and vomiting, option A अगर बोलता है, मान लीजिए कि 5-HT3 antagonist only, और एक ऑप्शन बोलता है 5-HT3 antagonist like ondansetron, peranosatron plus dexamethasone, that is a steroid, which one will be most effective? Then always remember, no, of course the combination therapy will be most effective. It's very simple, no, combination therapy will be most effective. So option B that we are having, you will be choosing option B. It is going to be more effective compared to a monotherapy again. But the drug of choice, it is going to be the drug of choice. 5-HT3 of course is the drug of choice. Okay, it's like this. What is the drug of choice for let's say a testicular cancer? What is the drug of choice for testicular cancer? We all know platinum compound, cisplatin. Okay, but most effective क्या होगा? The combination based therapy like BEP, BEP regimen, where there is a bleomycin, etoposide, platinum compound. Or I can say, what is the drug of choice for colorectal carcinoma? So a single drug or drug of choice for colorectal carcinoma is 5-fluorouracil. But what is the most effective is the combination therapy, the regimen like FOLFOX regimen, FOLFIRI regimen, where we are giving folinic acid, 5-fluorouracil and oxaliplatin or irinotecan. Making sense, right? Diphenhydramine, omeprazole, no, they are not coming under the regimen of chemo-induced nausea and vomiting. So aprepitant, it's the drug of choice in chemo-induced delayed nausea and vomiting. Chemo-induced delayed nausea and vomiting, delayed वाला term है, ठीक है. फॉक्स रेजिमेंट नहीं बोलते हैं, उसको बोलते हैं फॉल फॉक्स या फॉल फीरी रेजिमेंट. सो द ड्रग ऑफ चॉइस फॉर कोलोरेक्टल कार्सिनोमा, अगर एग्जामिनर पूछता है ड्रग ऑफ चॉइस इन कोलोरेक्टल कार्सिनोमा, then for that the answer remain 5-fluorouracil. As I said, this is just an example I am using, but the most effective will be this Folfox and Folfox or Folfiri regimen, where Fol stands for folinic acid. Another F that we are having stands for 5-fluorouracil. Ox stands for oxaliplatin. Folinic acid 5-fluorouracil, and IRI stand for irinotecan. Alright, so I hope it is making sense to all of you, and will give you your next case. There you go. Now you are having a 47-year-old man who is diagnosed with the mild rheumatoid arthritis, complained to physician joint pain despite ongoing therapy with ibuprofen. The man was a heavy smoker and had a history of chronic bronchitis with frequent acute exacerbation, usually treated with antibiotics. So he is having acute exacerbation. The physician decided to add a DMRD, disease modifying anti-rheumatoid drug. Which of the following drugs would be most appropriate for the patient at this time? Right? Which of the following? Is it hydroxychloroquine? Is it rituximab? Is it etanercept? Is it azathioprine? Go ahead, please. Which do you think is the most effective? Now, most of you might be thinking कि ऐसा क्वेश्चन तो नहीं देखा था पहले, right? But remember, where the patient is having chronic bronchitis, so bacterial infection is always and always very frequent. Immunosuppressant that we are having, immunosuppressant are usually not very much preferred. But if they are asking DMRs, which is very, very frequently preferred, or which is going to be preferred, it is HCQ that is going to be preferred, right? For this patient who is having rheumatoid arthritis, remember, HCQ is one of the preferred DMR, right? Can I use rituximab in rheumatoid arthritis? Yes. It's a biological, it is preferred, it can be used, it is one of the anti-CD20 monoclonal antibody. Can it be used? Of course it can be used. It can be used in multiple conditions, remembered by the mnemonic Krishna with a C, and CLL, rheumatoid arthritis, ITP, idiopathic thrombocytopenic purpura, inflammatory bowel disease, SLE, non-Hodgkin's lymphoma, autoimmune hemolytic anemia, right? Etanercept, it happens to be one of the TNF alpha inhibitor. Okay? Can it be used? Yes. But if looking at the present scenario, the drug that is most preferred is going to be hydroxychloroquine. Reason being, it is associated with the lesser side effect. Until unless the patient does not have, drug allergy, allergy to the drug, or G6PD, it's a highly safer drug that we can use. Azathioprine, again, it's an immunomodulator drug. It is going to cause immunosuppressant, and immunosuppressant usually can always cause flaring up of the bacterial infection, है ना? तो इसलिए उसको हम ज़्यादा यूज़ नहीं करेंगे. TNF alpha inhibitor, we all know the TNF alpha inhibitor, remember, is ice and आग. So ice के ऊपर आग, ऐसे याद कर लीजिए ना, ice and आग, that I used to tell you. Infliximab, है ना, infliximab, है ना, certolizumab, है ना, etanercept, right, adalimumab and golimumab. So ice and आग सबसे आसान सा mnemonic है, ice and आग. That is TNF alpha inhibitor, can be utilized in multiple conditions, including rheumatoid arthritis, inflammatory bowel disease, but not in this patient who is already having multiple frequent respiratory tract infection. Clear? So I think itni baat clear ho gayi. Moving on to the next one. Yes, Dr. Vijay, thank you, and all the other students. Let's move on to the next one. A 43-year-old man was admitted to the hospital with MI and was started on therapy that included atenolol. Which of the following actions most likely contribute to the mortality reduction obtained by beta blocker in MI, increased myocardial oxygen supply, decreased AV conduction, decreased myocardial remodeling, increased systemic vascular resistance, increased left ventricular and diastolic pressure. Atenolol, remember, it is one of the cardio-selective beta blocker. Be careful, it is having 5 options. So anyway, you have to choose only one option. Only one is correct in this one as well. आरती सर प्लीज बी फार्मा के लिए बी फार्माकोलॉजी डॉक्टर बी फार्मा में ऑलमोस्ट इतना क्लिनिकल चीज़ें तो नहीं रहती है बट बेसिक चीज़ें जो हम लोग डिस्कस करते हैं लाइक एएनएस और जनरल फार्मा में which is readily available on the Unacademy platform. So you download the Unacademy app and continue the learning. You will have a lot of lecture about it. You will have a lot of lecture about it. Remember that. So I hope you guys are understanding the question here that patient is having MI and we started on a therapy that also include a beta blocker, cardioselective beta blocker. Which of the following action most likely to contribute the mortality reduction? See, mortality reducing drugs are only very few like ACE inhibitors, ARB, aldosterone receptor antagonist and beta blocker. Now, which mechanism of action of beta blocker can actually decrease the mortality? That is it increase myocardial oxygen supply? See, it does not increase the oxygen supply. No, it decrease the oxygen demand. Supply कभी नहीं बढ़ाता है. बात समझिएगा, डिमांड को कम कर देगा, सप्लाई नहीं बढ़ाएगा. Decrease AV conduction, decrease myocardial remodeling. So it is having myocardial remodeling reduction property. So that myocardial remodeling reduction property is actually involved in the mortality reduction. ठीक है, it decreases myocardial remodeling. Do remember that. ठीक है, increase systemic vascular resistance, no, and increase left ventricular and diastolic pressure, no. So the correct answer that we are having is option C. It is having mortality reduction by decreasing the myocardial remodeling. Yes, so C is the correct answer and not any other option. Okay, very easy yet very conceptual question. Any second year student, those who have ever attended any ANS class, be it B Pharma, M Pharma or MD Pharma, anyone can answer this. A 59-year-old female recently diagnosed with atonic bladder, ठीक है, and the treatment with bithanicol was prescribed. Which of the following action most likely mediated the therapeutic effectiveness of the drug in the patient's disorder? So what is the patient disorder? Atonic bladder. The bladder is actually very relaxed, and for which the bithanicol has been given. So yes, that is another role. Beta blocker जब हम देते हैं, so it's actually any particular beta blocker can have that they are going to actually inhibit the renin release and ultimately they decrease the entire RAS system as well, and therefore the fluid volume over the heart will decrease. So that is how they are actually decreasing the remodeling, because how the remodeling it all started actually is due to the excessive fluid load. So fluid load को कम करेगा, remodeling process कम होगा. ठीक है, and additionally it is also having effect over the cardiac myocyte as well, directly myocyte पे भी affect. So I think all of you guys are giving a reply here with option A. Increased detrusor muscle tone, decreased ureteral peristalsis, decreased compliance of the bladder, increase the tone of trigone. Now if the person is already having what? Atonic bladder, see, let us say the bladder is actually in the relaxed form in this scenario, okay? And you are going to give a drug bithanicol. Remember, bithanicol is one of the M3 receptor agonist. M3 receptor agonist will always provide a contraction over these muscles. Now if the option A is telling, so let's start with option D. If option D is telling increased tone of bladder trigone, can you tell me If bladder trigone muscle, this is trigone, over the sphincter we are having the trigone. If the tone here is increased, what will happen guys? अगर tone यहाँ बढ़ जाएगा, so the risk of retention will be high. This will actually be causing urinary retention, right? So same as atonic bladder, the situation will further worsen out. Decreased compliance of the bladder. If the compliance of the bladder will decrease, again there will be retention. Decreased peristalsis, I mean urethra, है ना, ureter. अभी हम लोग तो we are talking at the level of bladder. This is telling ureter, decreased urethral peristalsis. N3 agonist will always and always have agonistic effect over the detrusor muscle. They are going to increase the tone of the detrusor muscle so that the urine outflow could be improved. Are you guys following me here? A is the correct answer. D, some of you have actually marked increased tone of bladder trigone. If it is going to increase, which is mostly seen due to alpha 1 agonist, that will be causing risk of urinary retention. Phenylephrine, epinephrine, they can always cause retention. Okay, next case. 49-year-old farmer came to the emergency department complaining of blurred vision, nausea, painful muscle contraction in his leg. He said the symptoms started soon after coming from his soybean field. The attending physician appropriately administered pralidoxim IV. Soon after, the man arrived. An agent from which of the following drug class most likely caused, or which agent caused the patient's symptom? Right? Go ahead, please. Which agent actually could cause the patient's problem? Is it adrenergic antagonist? Is it carbamates? Is it organophosphates? Is it alcohols? Which type of agent will be causing this problem that is shown here? Go ahead, please. See, all of you are marking. Okay, why not carbamate? Why not carbamate? So that's correct. Actually, let's save some time here. Organophosphate poisoning may, in the organophosphate poisoning, usually the drug of choice is going to be atropine, and after atropine you can use acetylcholine esterase reactivator, and the name of acetylcholine esterase reactivator is oximes, which is having drug like your pralidoxim, obidoxim. Okay? Yes. Now over carbamates, which is going to occupy both the side anionic and esteric, both the sides are going to be occupied. If there are two sides on the acetylcholine esterase, both of these sides are actually occupied by carbamate, compared to organophosphate, where a single side like anionic and esteric may, only esteric side is actually occupied. Only esteric side is occupied, anionic side is vacant. That is why in carbamate poisoning, this drug will not be effective. If the patient was administered this particular drug and the person responded, then most likely it is organophosphate and not carbamate. बात समझ गए आप लोग? Very good, है ना? So I hope it is making sense. Then in organophosphate, anionic side is vacant, and over this anionic side only, the drug like oximes that we are having, they will be binding here. Oximes will be binding, and they will form a phosphodiester bond with your organophosphate, and that will cause dissociation from here. It will dissociate, leaving both the sides vacant. Anionic and esteric side, both the side will remain vacant. Okay, so that's how it is going to be used. Similar question that examiner asked in the another examination. This is actually all MLE pattern question. A 41-year-old man was brought to the emergency department because of severe nausea, vomiting and diarrhea. Started 1 hour after a meal. Okay, he has taken a meal, but after that he is having this. The patient has excessive salivation, lacrimation, wheezing. Skin was moist. Pupils were myotic. Skeletal muscle movement were normal. Blood pressure 80/50. Pulse 46. Everything is, see where is it going? You know? Poisoning of this patient was most likely due to which of the following? Is it due to opioid? Is it due to carbamate? Is it due to atropine? Is it due to nicotine? Go ahead, please. I think it's pretty simple question. Pretty simple question. All of you, please try. Go ahead, please. Okay, that's very nice. That's very nice. As I can see, most of you are actually marking that it's mainly the patient is having cholinergic symptom. Cholinergic symptom that is mainly seen due to the irreversible acetylcholine esterase inhibitors like organophosphate or carbamate. Either of them could cause this problem. Organophosphate and carbamate, both of them can cause, because the patient is having all cholinergic symptoms: salivation, lacrimation, urination, diarrhea, and everything. So atropine will always increase the heart rate. Nicotine will also increase the heart rate. Nicotine is going to increase the blood pressure. It is the carbamate containing opioid that we have. It is having cardiac depression property. No doubt opioid will be causing meiosis, but other effect there will be no salivation, lacrimation. No, opioid is a salivation, lacrimation का कोई से नहीं है. Plus opioid is always going to cause fall in the blood pressure and decrease in the heart rate. ये cardiac suppressant है, cardiac depressant agent है. It will be causing fall in the blood pressure and heart rate. ठीक है. So although it is seen here, but lacrimation, salivation, wheezing, and after other symptom that is mentioned is not meeting with the opioid containing agent, है ना. So carbamate can be reversible also. It is mainly the organophosphate that is reversible. Carbamates are mainly irreversible only, है ना, because oximes are not going to be effective here. Sukhbir Singh. Okay, Dr. Sukhbir. It is organophosphate that is often reversible with the oximes if it is started at a proper time. Okay. Then this is one of the PYQ that has been asked previously. Which of the following adverse effect of SGLT2 inhibitor? Urosepsis, ketoacidosis, angioedema, or Fournier gangrene. These are the options A, B, C, D. 1, 2, 3, 1, 2, 4. Only 1 and 2 all are correct. Go ahead, please. I have asked this question in some previous sessions as well. I think we are about to finish just 1 to 2 more questions and then we are done. Go ahead, please. A, B, C, D. SGLT2 inhibitor drugs like your canagliflozin. Nowadays it is very much into practice. Most of the endocrinologists, you go to them, definitely they will give you one SGLT2 inhibitor, dapagliflozin, है ना, canagliflozin, dapagliflozin, empagliflozin, है ना, remogliflozin, है ना, ईवोग्लिफ्लोजिन, एक और हमारे यहाँ भी अप्रूव हुआ ईवोग्लिफ्लोजिन. ठीक है. सो मल्टीपल हैं. They are all inhibiting SGLT2 at the proximal converter tubule. ठीक है. And because of that reason, there will be glucosuria, and urosepsis or UTI is one of the very very common side effect. Ketoacidosis is also a reported effect, but angioedema that is usually seen due to bradykinin is not noted, guys. Fournier gangrene is another one that is reported, and on the basis of Fournier gangrene, examiner has already asked question in the AIIMS. So 1, 2 ka 4, 1, 2 and 4 is the correct answer. All of the above is not. All of the above is simply a trap here, which some of you have actually got into that. 1, 2 and 4. So this is one of the PYQ that has been asked in the AIIMS previously. So I simply asked this question again. Okay, a bank employee presented with symptom of depression for which he was started on escitalopram. So you should know which class of drug is escitalopram. Which of the following side effect is not caused by this drug? Sialorrhea, nausea, anorgasmia, right? नौजिया 2 बार हो गया है. एक और यहाँ पे लिख दे रहा हूँ, ऑप्शन डी विल बी डिलेड इजैकुलेशन. चलिए अब बताइए, with the escitalopram, which of the following side effect is not caused by this drug? Escitalopram, guys, remember which class of drug is escitalopram? It is one of the selective serotonin reuptake inhibitor, like citalopram, escitalopram, fluoxetine, and a paroxetine, sertraline. Their side effect is simply remembered by the mnemonic SSRI. ये बहुत आसान है याद करना. SSRI का side effect SSRI है. One of them will be known as your serotonin syndrome. And in the serotonin syndrome, the patient will have nausea, vomiting, the patient will have diarrhea, the patient will have vivid dream. And do remember this, nausea, vomiting, out of all of them is the most common side effect overall with the SSRI. Can also cause your headache, sexual dysfunction. Do remember, sexual dysfunction here is actually causing delayed ejaculation. Because it is causing delayed ejaculation, it's an FDA approved drug for premature ejaculation. PME I am writing, PME, premature ejaculation के लिए FDA ने इसको approved किया है. In fact, dapagliflozin is a drug that is specifically approved for the same purpose, है ना, anorgasmia, है ना, and some studies are also telling it decreases the libido as well. तो ये भी एक डेंजरस चीज है. रेस्टलेसनेस एंड इंसोम्निया. ठीक है. सो एसएसआरआई का साइड इफेक्ट क्या होगा? एसएसआरआई, वेरी, है ना, एसएसआरआई के साइड इफेक्ट एसएसआरआई. सो डिलेड इजैकुलेशन, एनोर्गाज्मिया, नाusea will be seen, but sialorrhea will not be seen. Sialorrhea is not something that is reported with serotonin. Remember, actually sialorrhea also is a wet pillow syndrome, is associated or reported with a drug जिसका नाम है क्लोजापिन. क्लोजापिन, इट इज एटिपिकल एंटीसाइकोटिक. ठीक है, एटिपिकल एंटीसाइकोटिक्स. ऑलराइट. सो आई होप कि ये बात भी आपको मेरी समझ में आ रही है. एंड वी आर डन विद दिस क्वेश्चन एज वेल. सो दिस इज द लास्ट क्वेश्चन दैट विल टेक. लास्ट क्वेश्चन, regimen that is used for Kaposi sarcoma. This is the last question. After that we will end the session. And tomorrow again 10 p.m. pe I will be available discussing some more clinical based scenario like I have shown you today, all MLE pattern question, because your pharmacology has now become clinical pharmacology, so all case based scenario will be there. Go ahead please. Regimen that are used for Kaposi sarcoma: BEP regimen, ABVD regimen, ABV regimen, Folfox regimen. Go ahead please. For the Kaposi sarcoma, which regimen could be used? Okay, so quickly I'll just give you the correct answer here. The correct answer that we're having ABV. ABV stand for your adriamycin, bleomycin, and your vincristine. Right, Folfox regimen I have just told you in one of the previous question here, that is for the colorectal carcinoma. ABV regimen is used for Kaposi sarcoma. BEP regimen, it is mainly bleomycin, etoposide, and one of the platinum compound like cisplatin. So they are mainly used for the testicular carcinoma. BEP regimen is for the testicular carcinoma. ABVD regimen, that is your adriamycin, again bleomycin, a G2 phase specific anti-cancer drug, vinblastine, vincalcaloids, and D for dacarbazine. Alright, so these are ABVD regimen mainly used for the Hodgkin's lymphoma, right? And we all know for the non-Hodgkin lymphoma we use R-CHOP regimen, है ना, rituximab, cyclophosphamide, hydroxydoxorubicin, oncovin and prednisolone. 8 से monoclonal antibody that is rituximab होता है. ठीक है, cyclophosphamide, hydroxydoxorubicin that is simply doxorubicin, O से oncovin, and P से prednisolone, that is the steroid. All right, so this was the last question that I wanted to discuss with all of you guys in this clinical pattern scenario. I hope you guys have learned something new. Like this was one question about a bank employee about escitalopram. Then I've also discussed about a patient who received SGLT2 inhibitor. Remember, it is causing another side effect like weight loss are the other side effect. In addition to that, it also causes weight loss. Remember, in addition to that, it also causes increase in the risk of fracture. right? I also gave you a case-based scenario of carbamate poisoning. I gave you organophosphate poisoning, and I also taught you how organophosphate can be differentiated with the carbamate poisoning. Then about a case-based scenario of bithanicol, atonic bladder, very very frequently asked. Remember about a patient, a beta blocker and myocardial remodeling, very frequently. In this I have also told you what are the mortality reducing drug in the cardiac remodeling, like ACE inhibitors, ARB, aldosterone receptor antagonist, triple A याद रखिएगा, triple A, ACE inhibitors, ARB, aldosterone receptor antagonist like spironolactone, eplerenone and B से beta blocker, triple A और एक beta blocker. Then I have discussed with all of you guys about one of the DMRs. Then I give you a case-based scenario in a patient with the Hodgkin lymphoma and chemo-induced nausea, vomiting. We have also discussed about long-term effect of steroid like osteoporosis. Another side effect also I mentioned. I have also given you a case-based scenario of a glaucoma. A combination of cluster of drugs are given in a single option. This is also being very favorite of the examiner nowadays in your NEET PG. I also gave you a case-based scenario of phenytoin in its teratogenic effect, post-operative shivering, what all drugs that are used, sumeperidine in this one, है ना. MRSA अगर टॉपिकल देना है, so in which of the following we will be using. I gave you a case-based scenario of nitroglycerin का side effect and how a patient will present, and other associated information about that, right? So this will be all, and I hope you guys learned something new. I'll see you guys in tomorrow's session, that is again 10 p.m. पे we'll be meeting you guys again for clinical based scenario. So be ready for some more clinical brain that will tickle your brain, and we will try to find out the answers after discussing. Okay, thank you very much guys. Have a good night to all of you guys. If there are any more query that you guys needed, definitely you guys know where to message and tag me in any of the social media. Unacademy के टेलीग्राम ग्रुप पे आप मैसेज करके आप मुझे टैग कर दीजिए. We'll try to take that on. Thank you very much. Have a good night to all of you.